Hello, everybody. I'm very happy to be here today to talk about artificial intelligence applications in medical imaging and radiology. My name is San. I'm the director of Infovision Europe. Infovision is an AI company that specialized in creating AI applications in the medical field. So we have years of experience in creating AI applications, and today I would like to talk more about the aim of creating AI applications, what kind of applications we have created, the background of those applications, the methodologies of creating those, as well as their applications in recent cases. We have created an AI algorithm for COVID-19 triage and follow-up, the methodology about how we create it, and the aim of creating such an AI. We have written down in a paper, and it has been published in the Lancet Digital Health. So I would like to talk more details about how this AI was created, how the data was collected, how a model was trained, and what's the result that we are able to get from it. The background of this study is about in the beginning of the breakout of the COVID-19, there has been a lack of convenient tools at that time for quick detection of COVID-19. At the beginning of the breakout, the RT-PCR tests were not sufficiently available in most of the hospitals. So CT was frequently taken in order to determine whether there were lesions in the chest, as well as clinical symptoms. Of course, as the first line of determination whether the patient is suspicious of COVID-19 or not. And then once the patient was thought by the radiologist of being suspicious of COVID-19, the patient will be sent to relevant fever clinics and possible isolation. So the faster the triage is done by the radiologist, then the less time the patient will be in the waiting line, and the less chance of cross-infection of the COVID-19 patients with the other patients in the hospital will happen. So at that time, the triage is a quite tedious work, and the triage we aim to create AI that match the standard of radiologists in terms of being able to triage, so that more time can be saved in the workflow of the hospitals when the COVID-19 break out and got worse during the middle of the year. At the same time, we have to take note of another situation as well. That is, this AI tool should be able to be adopted into different prevalence scenarios as well, being high prevalence, low prevalence, or middle prevalence. Besides the detection part, it's also noteworthy that this AI will also be used for monitoring the intensity of the patients, yeah, for those who have already been admitted into the hospital, to see whether the treatment plan works, whether the patient situation gets better or not. And that will be critical for the hospitals to plan its resources wisely, so that more patients can be cured. So the data methodology of this research proceeds as following. In the initial step, the data was collected from a single source. Then the AI was developed. Of course, certain images were taken out as the internal validation set, and the validation was performed against this internal validation set. Afterwards, external triage validation will happen, and the data will be from different prevalence regions. Of course, they will also be different from the data collection point, so that external validation can take place. And the images for external validation were taken from three different hospitals. Each one are located into different places in China, and they have different COVID-19 prevalence rate, yeah, or incidence rate. And the lesion burdens were analyzed besides the external triage validation that has been performed. And that is to measure whether AI and radiologists can successfully predict in the same direction whether COVID patients has the lesion burden increased or their lesion burden has decreased. So initial step of data collection, actually there were more than 5,000 of images were collected at the beginning, and after filtering through different criteria, in the end there are more than 1,000 images that has been taken in the training data set, and there are more than 500 images have been taken in the internal validation data set. Procedure has been performed for the validation of external data sets as well. The data from 3 different sources were collected and annotated, and at the same time the criteria has been applied. In the end, more than 1,000 images were also taken inside of the external dataset in order to measure whether this AI is able to perform equally well in the data outside of the initial training dataset. And there is another point that we should take note of, because the aim of this AI algorithm is not about checking on the ground truth of whether this patient has COVID or not. Yeah. The RT-PCR test will not be used as a reference standard. Instead, the radiological report will be used as the reference standard in this research. That means that we are trying to create AI that matches the initial interpretation of the radiologist into the radiologist believe that this patient is suspicious of COVID or not based on the CT image. So if the radiologist report that saying that there is a clear mention of suspected COVID-19, or there is ambiguous impression but presence of COVID-19 related imaging features, then we will classify them into COVID-19 positive cases. Then if they mention about ambiguous radiological findings and absence of COVID-19 images or absolute no radiological findings, we will classify them into COVID-19 negatives. And we are going to compare the results of AI in categorizing the images into those 2 categories against the doctor's reference standard, in which we derive from the radiological report from the radiologist. We can see from the ROC curve, and in the internal validation data set, the area under curve value is very high, 98.5%, and it is higher than the AUC of the external validation set, which is 95.3. This is understandable since usually the internal validation results will be better than the external validation result. It is also noteworthy that the result from the external validation in one hospital, Tianyu Hospital, area under curve is actually 96.6. That is higher than the average of the external validation set, which is 95.3. And the Tianyu Hospital being the hospital that has the highest COVID-19 prevalence rate. So actually the prevalence rate does impact the performance of AI in terms of triage. And this triage performs better in terms of predicting the COVID-19 positive cases in a high prevalence settings. But as we mentioned before, it is noteworthy that this is not a comparison against RT-PCR, the golden standard. It is a comparison against the radiological findings in order to minimize the steps taken to triage the patients. To measure the efficiency in triage, time saving is one essential point. As we all understand that it takes some time for the radiologist to draft the radiological report about each case, and also the case will be read by a second reader normally, and also afterwards the report will be confirmed and sent to the clinician, the fever clinician in charge. So those time accumulated are actually quite some minutes or quite some hours in certain cases. And the AI, however, on the other side, just concentrated all the way. We give them electricity, they continue running. And the AI triage time on average for each case is actually below 1 minute into giving out results that is similar to the results mentioned in the radiological report in those cases. And that has a very practical meaning to the betterment of the workflow during the initial breakout of the COVID. Yeah. A lot of patient doesn't have to wait for radiological reports to be given out before they were assigned or allocated to the right place within the hospital to get COVID-related treatment. Besides the detection part of the research, we actually also very interested in AI's function in terms of determining the changes of the lesion burdens. On this part, we try to see the correlation between AI's decision and radiologist's decision. And we find out that the AI and the radiologist, most of the time, they make correct prediction about whether the same patient condition, the lesion has increased in size or decreased in size, meaning that their condition could be worsened or their condition could be better. So that actually also contributed to the time saving in terms of determination of whether this particular COVID patient's condition has become better or has gone worse. We find out that between the AI and the radiologist on average, yeah, the correlation has a high Cohen's kappa coefficient of 83.9%. Yeah. That means that AI more or less matches radiologist standard in terms of identification of changes in the lesion burdens. AI methodology, that's how we collected the data, how we validated the data, and how it has been put into use. This part has a lot of practical values when the COVID break out and when there isn't a sufficient method in terms of quickly identification of lesions, as well as measuring whether the patient has the condition has become better or become worse. So AI has a lot of positive impacts, yeah, when we implemented them in the hospitals. But at the same time, we have to acknowledge there are some limitations of it. Yeah. For example, the training source limitation. The data was only collected from one hospital in this research. So that means that probably the model trained is not robust enough, as we also see that in the external validation data set, its performance is not as good as the internal validation data set. And it also limited by the simple UNet structure. So the convolutional neural network is not optimized for this particular case. And we can see how different network structure will impact the performance AI later in my presentation of another paper. And the third limitation is that we assume that here doctors will respond instantly to the results of the AI triage. Yeah. However, in reality, that may not be the case. Yeah. The alert may be beeping for some time before our fever clinicians take care of these children, or our nurses assign this patient to the right workflow stream. There are many implications, administrative implications, or practical concerns that we have to take note of to see how exactly effective AI's triage is able to help within the hospitals. So even though this research about how AI's triage can match the similar level of radiologist and matches a similar level of radiologists in terms of determining the COVID-19 lesion burdens has increased size or decreased in size, we also need to note that in practical sense, there are a lot of factors that also play in the correct control of in-hospital infection. And the improvement based on this algorithm has been completed, And this algorithm has been wrapped into the actual application with a lot of additional data into the training data set. And this algorithm has been used in 14 countries in Europe, for example, Germany, in France, in Spain, in UK, in Belgium, Italy, and so on. So we believe that this algorithm has a large potential in terms of improving the efficiency of our doctors in diagnosing, and more importantly, giving confidence during the diagnosis process. Yeah. Hopefully, the AI can serve our radiologists better and making them more confident radiologists in diagnosing while saving lives at the same time during this period. And I would like to move on a little bit from the AI algorithm that we used for the detection of COVID-19. I would like to move on a little bit to the AI algorithm that we use for malign and for benign and malign nodule detection. And that actually is one research we have worked on for quite a long time. And that one, the background of that research is that lung cancer has a quite high morbidity and mortality. And also, malignancy prediction in practices has become more and more important in terms of giving follow-up suggestions or thinking about treatment plans. As we discussed before, there has been AI models that we had before. However, the improvement of the existing AI algorithm, the improvement of the existing convolutional neural network features can possibly have contributed to the betterment of the results in the end. This research, it actually has a simpler methodology. That being that after the images were taken, the nodules were taken out and annotated, and against a certain ratio of benign nodules and malignant nodules. And the nodules, the benign and malignancy, were determined by the ground truth of 5 years follow-up images as well as biopsy results. So after the image labeling took place, image enhancement also take place as well to enlarge the data set and balance the data set. And among them, certain nodules were chosen to be inside of the training data set, and the rest of nodules will be in the testing data set. And improved structure convolutional neural network is taken by adding different layers into the existing 3D UNet. I'm not going to go to the details of how the improved structure works, which layer will contribute to the betterment of results in the end. However, I would like directly the analysis of the improved DL model and the conventional 3D UNet results. So the ROC curve of the improved DL model is on the right, and we can see there is an area under curve of 84%, and on the other side, the area under curve of the 3D UNet model is 81%. We can see there is a slight increase in terms of performance for this new model. And we also are interested in comparing whether this improved model is the similar level of our radiologist prediction on whether this nodule at the current stage is malign or benign. So we take a closer look and compare it against our radiologist initial impression on those nodules. And we see that the sensitivity and the specificity actually for the DR models are slightly higher than the radiologist. Maybe that is because the AI is able to see something beyond the images. However, we also need to acknowledge that there are the limitations of this study in terms of the absence of external validation site, because it is validated within the data set instead of taking an external data set in terms of validation. And this is just one research about malignancy and benign nodule prediction in the future. And this study together with a lot of other studies, constitutes the foundation of building an AI algorithm that is able to be placed inside of the clinical flow of our doctors. As we know, from the same thoracic imaging, so much information can be derived from it. And each study that we are trying to complete may only be a small piece of the puzzle that we are trying to patch up. And to have AI fully integrated into the workflow of our doctors, and to have it be a very powerful tool of our radiologist. It stays by the side of our radiologist to give confidence and accuracy and contribute as a essential helper of the diagnosis process. There is still a long way to go. But with those information, with those researchers that we have completed, we have somehow already contributed to this process, and we are moving forward to the goal of being the ultimate tool to help our radiologists in terms of having more confidence in diagnosis and having great accuracy in terms of diagnosis and giving out treatment plans. And that's all for me about the AI application side, that we have put inside of research, how we transform them into the applications that our doctors can use on a daily basis. And I would like to thank you for your attention, and looking forward to any questions that you have about my presentation. Thank you.